So we are ahead of schedule, which is awesome. And I will try to continue to be ahead of schedule because what we really want is for people to have the opportunity to talk and discuss and hear from all of the folks who are here around the table. So I'm Alison Stuebe. I am a maternal fetal medicine doc at UNC, and I am so excited that this is actually happening. I found some emails from December of 2014 when Sarah and Kristen and I were first kind of batting around this idea, and so it's been a little bit longer than a normal gestation to get here, but it's just incredibly exciting. I'm also excited because this is the 15th anniversary of my taking my first child home from the hospital. And so you can see that my husband and I look absolutely terrified, appropriately. And I look kind of goofy standing outside with the car seat thinking, oh my God, what have I got myself into? But, so I started my fourth trimester about 15 years ago, the first time. I also am not sure that it necessarily ends, as my 12-year-old last night at 1 a.m. was having trouble sleeping. So the sleep and fatigue piece of the fourth trimester apparently is not bounded by anything. Although it certainly does get less frequent as we move along. So today I want to introduce this conference and talk a little bit about what we mean by patient-centered. And so we'll talk a little bit about the concept of patient-centered research and PCORI's mission and goals. And then I want to just give a quick overview of some of the issues in the fourth trimester. And then the rest of the day is going to be about how we might do a better job meeting the needs of moms during this critical period of time. So patient-centered, what do we mean by patient-centered? Pretty intuitive, potentially, but we'll talk a little bit about PCORI. So PCORI's vision is that patients and the public have the information they need to make decisions that reflect their desired health outcomes. So when you're faced with a clinical problem, you know what you need to know to choose the thing that's going to work to actually make that problem better. And the PCORI helps make informed health decisions and improves healthcare delivery and outcomes by producing and promoting high-integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. So that's the people in this room. And what we're hoping to do over the course of this project, which is today's meeting, webinars, and another meeting in a year, is to begin to lay out the critical questions about the fourth trimester and decide what it is we need to know to be able to enable moms to make decisions and meet their healthcare needs. So what we hope will eventually grow from this is some studies and some tests to say, well, gosh, would it help if I got, daily text messages telling me I'm doing a good job versus a nice person coming to my house twice? Neither of those are probably the answer, but we want to come up with some ideas and some concepts, and then we'll test them, and we'll see what works for which moms so that we can deploy them more broadly. So patient-centered research leads to better questions. The research focuses on the issues and outcomes that matter to patients and caregivers. Sometimes we academics can get really caught up on measuring, what can improve potassium levels over time, and it's nice to improve potassium levels, but the individual patient doesn't say, gosh, my potassium's feeling great today. So we want to get beyond measuring outcomes that the scientific, nerdy people think are important to the ones that actual people think are important. We also do better studies and get more patients involved if patients have helped design the project. So if we have an idea for something and the moms say, you know what, that is just not going to work, then we don't get funding to do a study, to do a project that moms say, no, I don't want to do that, that's ridiculous. Ideally, we design something that moms say, that is awesome, and we would want to be a part of it. And then finally, if we design studies that answer the questions that matter to the caregivers and patients, that information is more likely to be applied in real life. We'll use that work and actually implement it if it actually is something that meets a real need and not a perceived need. So I want to just touch on some definitions. Comparative effectiveness research is designed to inform healthcare decisions by providing evidence on different treatment options. And comparative effectiveness research looks specifically at effectiveness, which means does this work in the real world? And that's different from studies that look at something called efficacy. So an efficacy trial usually enrolls a select group of patients that excludes people who have other issues. It's narrowly focused to make the study really tidy and clean. And what we found is something can work really well in a study, but then when you put it out in the real world where it's a little bit more complicated and muddy, that same intervention may not work as well. So effectiveness says, does this work in real people in the real world, not in a select group of people who sign up for a study at an academic medical center? And those studies are also supposed to measure the benefits and harms of different outcomes in ways that matter to moms and patients. And the concept is to compare different drugs, medical devices, tests, surgeries, or ways to deliver health So we'll think today about what different options for addressing the challenges moms face could we test, and how would we do that. So I also wanted to talk for a moment about patient-reported outcomes, and I've already kind of dissed potassium measurement as a patient outcome. But a clinical outcome or a lab outcome might be measured in a test tube. Something we send to the lab and get back and say, your CRH level is this. A patient-reported outcome is an outcome a mom or a patient can describe. So it's when we ask somebody, are you doing better? And they say, well, gosh, I feel like I can get what I need to get done today because this intervention is actually working for me. And in order to measure that, we need to come up with questions to ask. And the Patient-Reported Outcomes Measurement Information System has tried to develop standard questions to measure different things that are important to people's health and well-being. So there are questions about sleep, there are questions about physical activity, there are questions about being able to get the tasks done you need to get done in the course of the day. But one of the really interesting things is that to date, those measures have not taken into account parenting and birth, or being postpartum. And as an example, there are a lot of questions about sexual function. And I think we all agree that sexual function is an important outcome. And they ask specifically about what might be interfering with sexual function. Well, here are their questions. How much has a medical device, for example, port, colostomy bag, or oxygen tank, affected your satisfaction with your sex life? How much have scars from surgery affected your satisfaction with sex life? Well, that maybe you could apply to a C-section or to a vaginal birth. How much has breast tenderness and enlargement affected your satisfaction with your sex life? Kind of getting it postpartum, but not directly. How much have hot flashes affected your satisfaction with your sex life? Nowhere is how much has the baby screaming down the hall affected your satisfaction with your sex life? Or how much has being sucked on and held and snuggled all day affected your desire for anyone to touch you? So those are not the exact questions that the promise measures would probably endorse. But part of what I'd love for us to do is think about what questions would we ask moms about how their life is going, well or not well, that would really get at the issues in the fourth trimester. Because right now it is not on the radar on these measures. And so one of the things we might decide is we want to develop those kinds of tools to really understand what it's like to be a mom and know whether the thing we're doing to make it better is actually making it better in a meaningful way. So we're going to be looking at 3 overarching questions today, and I'll come back to this at the end of this presentation. What issues do new mothers face for which we don't have an evidence-based approach? So that I feel like somebody's been sucking on me all day long and my partner really wants to get it on and I don't want to. Problem, I don't think we have an evidence-based approach for handling that. I'm not sure that there's a generic evidence-based approach for handling that, but what would be the conversation? How could we talk with moms? Who should talk to moms? What's going to work for moms to navigate that? I don't think we have any evidence for an answer. So that might be a clinical question that we want to get at. Then what issues do we know how to address, but we're not effectively communicating or providing that solution to women? So there are some things where we have helpful strategies. We have evidence-based treatment for postpartum depression, but we know many of the women with postpartum depression don't get treated. So there's a gap between the thing we know how to do and moms actually getting the care that they need. And so that's a different kind of issue. And then what outcomes might we measure to measure whether moms' needs are met? It's a little circular. There should have used a different word. And how do moms define optimal support and care? So if we were going to give a mother a questionnaire at 12 weeks postpartum saying, how did it go? What would we want to measure to know that we've done a good job supporting women? And unfortunately, I slept for 10 hours in a row every night is not an attainable goal, so we don't want that to be our measure. Like if she got 10 hours of consolidated sleep every night, then we won the game. It's going to be a hard game to win. But I think we can say that moms felt supported, moms knew what to expect, moms felt empowered to get care when they needed it. Those are the kinds of things that we might want to ask. And I want to get everyone around the table thinking about what would those outcomes look like. So then I just want to give a little bit of a backdrop about the fourth trimester so that we're kind of starting from the same page. And I think it's important to think of this in terms of evolution and in terms of the needs of new babies, which are many. And when biologists think about different kinds of mammals and their behavior, they often classify newborns as either altricial or precocial. And altricial newborns are like kittens and puppies and mice who are born with their eyes fused and their ears closed and they're hairless and totally dependent. And they often are in a nest and they can't do anything on their own. The altricial newborn is contrasted with the precocial newborn. The precocial newborn is usually an animal that lives in a herd and within an hour of life is standing on 4 legs. and is able to then travel with the herd under its own locomotion from within moments of birth. Now, primates are kind of in the middle somewhere, right? Because newborn babies are not hairless with their, well, sometimes they're hairless, but often with their eyes fused and their ears closed and totally incapable of doing anything, but they're certainly not standing up and walking around within hours of birth. And that may reflect the fact that there's an enormous amount of brain growth that happens after the baby emerges from the womb. And so some have argued that humans are secondarily altricial. So they're not altricial in the sense of being totally dependent, but they need a whole lot of care in those first weeks and months. And so this is my niece Ayla being snuggled when she was very much secondarily altricial in her first few weeks and months of life. So it's also interesting when we think about mammalian behavior and feeding. So this is a study that looked at the composition of milk in different mammals. If you look at the kangaroo or other marsupials, they feed continuously. They have a pouch, the baby's in the pouch, the baby's attached to the mom's teat, and they just eat 24/7. Their milk is very low in fat and dilute because the baby can just keep drinking it all the time. Contrast that with marine mammals like whales, and they feed quite infrequently. And they have very high fat and concentrated milk. Animals that hunt, like dogs and cats, are a little bit less concentrated, but their mothers have to be able to go out and catch a meal and then come back to their puppies. And so their milk is designed to be fed at infrequent intervals. Human babies are a lot closer to kangaroos than to dogs or to whales. And so to some extent, the primate infant expects to be continuously fed. And for most of our primate cousins, there's a solution to this problem. Mother primates are really hairy, and their babies have hands and feet that can grasp. And so this little gorilla is able to continuously feed, almost like a kangaroo, while mom goes about her business. Humans have lost our very, very hairy chests, for the most part, and our human babies cannot grab onto us. And so that creates a problem. In order to move around as a human mommy, you need to have a way to hang on to your baby almost continuously. Robert Martin, who's an anthropologist, has concluded that at some stage, infant carriage in humans must have undergone modification of some kind due to the combined effect of extensive reduction of body hair and suppression of the grasping ability of the foot. However, the most likely sequel was development of some alternative means of infant carriage, e.g. with a sling, to maintain close mother-infant contact, rather than deposition of the infant and secondary development of suckling on schedule. So biologically, babies expect to be held most of the time. And unfortunately, modern Western culture doesn't teach moms about baby wearing necessarily. And so moms are left with, oh my God, this thing wants to be held all the time. How am I gonna get through my day? And unfortunately, that has led to the development of lots and lots and lots of books to tell you how to cope with the fact that you don't have hair and your babies can't hold onto your chest. And 15 years ago, when I was at home with Noah, The Secrets of the Baby Whisperer had recently come out, and my very well-intentioned mother-in-law saw the Baby Whisperer on the Today Show and sent me this book and said, oh, here's what you need to take care of Noah. And I was supposed to feed the baby. We were gonna do eat, activity, play with the newborn, who doesn't really play, and then sleep. He was supposed to take a nap while I got to do what I needed to do and have some me time. Well, let me tell you, this is not easy. But I killed myself. I didn't kill myself, but I went crazy for days trying to put Noah on the schedule and believing that I was a failure as a parent because I couldn't do this easy thing, which obviously was not easy. And so I think that conflict between the expectation that there's a magical solution that will allow babies to be really low maintenance and the reality that they expect to be held all the time creates a lot of tension for moms. And then there are all the other things that mothers need during this time. And it was more than 40 years ago that Sheila Kitzinger stated, there is a fourth trimester to pregnancy, and we neglect it at our peril. It is the transitional period of approximately 3 months after birth, particularly marked after first babies, when many women are emotionally highly vulnerable, when they experience confusion and recurrent despair, and during which anxiety is normal and states of reactive depression commonplace. So this was 40 years ago. I was a baby when this was written. And I really don't think we've made much progress in making things better for moms in this critical period. And I'm so hopeful that the conversations we have today will begin to change that dialogue. So what other things do moms have to deal with in addition to this highly dependent creature? Well, there are a lot of problems moms face in the first 2 months. And we're going to be talking about all of those issues today over the course of the morning. But what you see from this graph is that 20% of mothers are struggling with many of these issues. And that's all while caring for this incredibly dependent little person. We also know that we don't do a good job in maternity care addressing these issues. This looked at midwives, family doctors, and obstetricians, and nobody got over 60% on addressing these important issues to moms, with the exception of midwives talking about birth control, where we got almost up to 80%. But importantly, things like how long to wait before getting pregnant again, which is kind of important for the discussion about birth control. Less than half of women said they got enough information on this important topic. So moms aren't getting advice on the things that they care about. We also know that moms continue to have pain after birth. 18% of mothers a year after C-section continue to have C-section scar pain. And we don't have any interventions or any data about what to do about this. So it's a real issue if 1 in 5 mothers a year later is still uncomfortable and we got nothing to offer them in terms of how to address them. So what support do we provide? Well, I'm being provocative here, but I like to say that once the candy is out of the wrapper, the current system is really not interested in the wrapper anymore. And we focus an enormous amount of attention on babies, but we sort of treat mothers like, oh, we'll see you in 6 weeks till you can have sex again, have a nice day. And we're here to change that and to begin to discuss how we can take care of mom and baby after baby is out. So, okay. So this was more data from listening to mothers, where they found that 1 in 4 moms didn't have a telephone number of a care provider to contact for concerns in the first 2 months after birth. So not only are we not doing a good job of addressing all these unmet needs, we're not even telling people who to call when they leave the hospital. And so we clearly moms need to know someone to call, because I will tell you, I remember that first night 15 years ago, and I was panicked, and luckily I knew who to call, and I didn't actually call, but if I hadn't had a number, I would have been even more panicked. And I think that we really need to do a better job of knowing, of making sure moms know what their resources are after discharge. We also know a lot of mothers don't come to their postpartum visit. Among Medicaid moms, commercial Medicaid HMO mothers, 40% didn't have any postpartum visit in 2013. Some of that may reflect the fact that the postpartum visit isn't meeting mom's needs. Some of it may reflect structural barriers to accessing care. But it's kind of crazy that one can give birth and not have any contact with the healthcare system thereafter. This is a health equity issue. In an analysis of Medicaid mothers, predictors of not getting that postpartum visit included Black race, alcohol or drug use, mental health disorder, or living in a neighborhood where a high proportion of individuals had a low educational attainment. Ensuring all women are engaged in the support they need is an essential step for us to achieve health equity. And then we just don't have good evidence. Wendy Broderick, who's an Australian general practitioner, did a literature review of clinical guidelines for postpartum care and found there wasn't much guidance. And the guidance that was there was, well, we think this probably makes sense. And we don't do that for other important health issues. We don't say, well, we don't know what to do when you have a heart attack, but we think it probably makes sense to give you a beta blocker, right? Like, no, we have studies. And so we need to generate some evidence so that we can address these issues. And then there's the fragmentation of care. So for most women, unless they're fortunate enough to have a midwife or a family physician, there's an obstetric provider and a pediatric provider. And those two providers are often saying, and I see this especially with breastfeeding, well, the OB says that boob is in the baby's mouth, so it's not really my problem, so I'm not going to deal with it. And the pediatric provider says, that boob's attached to mom, so it looks like it has mastitis, but you need to call your OB provider because I can't take care of that. Lactation consultants tend to be very focused on what I call the orobubular interface, and they do a fabulous job with that. But even those who appreciate the broader context are typically not licensed to prescribe, so they can't treat all of mom or all of baby. The mental health provider may be very focused on mom's brain and her mental health. The family planning person might be very focused on mom's uterus. And the net is that the mom is sort of chopped up in all these different pieces that don't address the totality of her needs. So today we want to take these 6 domains that we've proposed: mood and emotional well-being, infant care and feeding, sexuality, contraception and birth spacing, sleep and fatigue, recovery from birth, and medication, substances, and exposures. And we want to bring them together so that we can talk about the 4th trimester in the ways that all of these different issues intersect. Now, I want to just give you all a metaphor. How many people have read the book, The Life-Changing Magic of Tidying Up? Are people familiar with this book? So the concept here is that you take everything that you own in a particular category, like all of your shirts, and you put them all in a huge pile on the floor. And then you pick up each item. And if it brings you joy, you keep it. If it does not bring you joy, then you discard that particular item. And that is a way to clean out your closet. It actually works. I got rid of 21 bags of stuff doing this. Today we're just putting all the stuff on the floor, and I know I'm out of time, I had 30 minutes and I set the timer for 20 minutes. So we're going to bring out everything and put it on the floor and make sure that we've got everything out on the table. And so today we may not end up coming up, we're not going to solve all of the issues that we raised today, but we want to inventory all those issues and raise them and surface them so that we're aware that they're there. So whatever is in your postpartum closet, whatever you think we need to attend to, we want to make sure that we've thought about it and considered it and put it out there. And then over the course of the year, through webinars and through a follow-up meeting, we'll begin to refine that and see which things bring us joy or sorrow that need to be addressed, and which things are like, you know what, we're not going to fix that, or that's not as big a priority. But I want everybody to feel free to raise issues and contribute things so that everybody can feel free to be part of the discussion. So these are our overarching questions. And I look forward to a vibrant discussion and everybody having time to talk about what's important to them as we move forward on this today. So thank you.